I think we're just 1 minute past the hour, so probably worthwhile getting started because we've got a really full program today for this first Alpha-1 antitrypsin patient conference. So first, to introduce myself, my name's Pippa Powell, and I'm the director at the European Lung Foundation, and I'm really honoured to be able to introduce the first Alpha-1 antitrypsin deficiency patient conference. We're absolutely delighted to have a really international audience here today. We had over 300 people registered this morning for this event from more than 30 countries. So all of you are extremely welcome wherever you are. We know some people will join us at different times during the day, depending on where they're located. But just to assure you that this session will be recorded, and if you do miss any parts, it will be available to watch back later. The first thing I'd like you to do is to draw your attention to the possibility to have this session translated. We have live translation available today through the Wordly app. It provides automated translation into more than 50 languages. So we really hope you'll be able to log into that and be able to see the translation that will come alongside the person talking. You can use the app within Zoom, and you can use the link that will be posted in the chat box by my colleagues that will take you to the site where you can choose your language and you can read along with the conference. We found in previous conferences that this tool is really useful to help people understand, but it's not perfect. So we apologise if there's any words or phrases that get muddled, but we hope it helps this event be more accessible to more people. So November is Alpha-1 Awareness Month, and today's event has been organised by us at the European Lung Foundation, but in partnership with the Alpha-1 Europe Alliance and the ERS Clinical Research Collaboration, EARCO. You will hear more about the Alpha-1 Alliance and EARCO in the first session today and in session 3. And we will be adding throughout the day links within the chat for you to click on and find more information. So first, I'd like to tell you a little bit about the European Lung Foundation. We're an organisation led by patients, and we work across the globe to bring patients, the public, and healthcare professionals together to advance diagnosis, treatment, and care for all lung conditions. One way that we found is really important and really impactful is by running patient conferences just like this one. The aim is really to help you as patients learn more about your condition, but also to give you the chance to ask questions of experts, and just as importantly, to ask questions of other patients. We think personal experiences are hugely important in self-management of diseases, and we have some amazing patients here today to tell you about their experiences and their lives living with Alpha-1. So we've been hosting these patient conferences for a number of years now, and many patients have told us, along with their families and friends, that they've learned a lot from these experiences and that the event makes them feel less alone. One quote I remember from a bronchiectasis patient conference was a 70-year-old lady who said it was the first time she'd ever really understood about her condition and what she could do to help herself. So it's a really great opportunity to see how dedicated the healthcare professionals are into improving care and treatment for all of us. And there are also very many healthcare professionals who are joining us during this conference today, and we welcome them too, because we know they're eager to find out how they can better support their patients. So we would especially like to thank today Marion Wilkins and Karen O'Hara. They're going to be a key part of this conference. They're speaking and chairing in sessions, but they've also put an enormous amount of time and effort into planning this event. They've designed the programme, they've identified the speakers, and they've really worked with the ELF team, and particularly Jeanette, to ensure that the conference runs as well as possible. So just a few housekeeping notes. This is a webinar, so you can see the speakers and the chairs and the hosts, but unfortunately you can't see the other attendees and they can't see you. That's really to help us make sure that there's sort of no interruptions during the course of the event. But we really welcome your input. Please talk in the chat, make comments, you can talk to each other. If you have very specific questions for any of our speakers, then please post those questions in the Q&A section. That's where we will be looking to post questions to our speakers and hosts. As I said before, we are recording this event, so it will be available on the ELF website and the European Respiratory Society Respiratory channel, so that others can freely watch the event afterwards. And you'll receive an email as soon as that is available, so you can watch back. Again, just to really encourage you to put your questions and answers on the question and answer board. The more questions we get, the better. We find these events are most impactful when we get questions from you and we can pose those questions to our speakers. There are expert clinicians answering your questions today, but please do bear in mind we can't answer personal questions about your personal circumstances. So questions should be more generally about the disease or the presentations that you've heard. Some of our speakers have polls as part of their presentations. This is where we will ask questions of you and you'll have the chance to vote or tell us what you think. Please do take part in these. It will really provide valuable information to us about you and your experiences. If you're on social media, join us there. We will be posting about the conference all day. We'll be using the hashtags Alpha-1 Patient Conference and EARCO Alpha-1. If you do post yourself, please tag ELF, Alpha-1 Europe Alliance and the European Respiratory Society using their Twitter handles, which is shown here on this slide. We have a big ELF team here helping in the running of this event today. So any questions, any problems, please do email info@europeanlung.org and we'll be able to help you out. So the programme for today, this is the exciting bit. What are we going to hear about? So today has been split into 4 sessions and each session will have their own individual chair. Each chair will introduce the speakers of the session. They'll keep them to time, they'll coordinate any questions that are asked within the Q&A, and then there'll be time at the end for those questions to be answered. You can access the programme by clicking on the resource icon on the bottom of the Zoom screen. Hope you can see that. It is also available on the ELF website, and we'll put the link in the chat now as well. You can also view info about all of the speakers you'll hear from here as well. So we're really grateful and fortunate to have highly knowledgeable speakers who are leaders in the field of Alpha-1 antitrypsin deficiency and other respiratory conditions. But we also want to learn from patients, we want to learn from you, and we'll be hearing from people who live directly with Alpha-1. So a final reminder to please post your questions in the Q&A box. Remember, there's no silly questions. You can also put a thumbs up if you like a question, which will move that question to the top of the priority list and will help our chairs decide which questions to ask. So now I'm going to ask Claire, who's in control here, in mission control at ELF, to post a poll. And this poll will help us to determine how impactful and effective this session is today. So the question that we're asking you is to rate your current knowledge of Alpha-1 antitrypsin deficiency. And the rating is from 1 to 10. 1 is where you think you know nothing at all. And 10 is where you think you're pretty much an expert. You really know quite a lot about the condition. And we'd really like to see the scale of where you are on here. And we will run this poll again at the end to find out how we've helped you progress along the scale through the course of this session. So I still see some votes coming in. So thank you everyone for letting us know how you feel your knowledge and understanding of Alpha-1 is. And while we just finalise the poll, I'm going to hand over to Karen O'Hara, who is our first chair, and she will introduce herself to you. She is a person living with Alpha-1 antitrypsin, and as I said, has been really pivotal in the organisation of this event, and she will lead you into and take you through session 1. So the poll is finished. Thank you everyone for your answers, and Karen, it's over to you.
Thanks, Pippa, for your lovely introduction. It's my pleasure to be introducing the first session. As Pippa said, I'm an Alpha-1 patient, so I've been living with Alpha-1 for many years. You'll hear a bit more about my story later on today. So this first, I should give you a little bit more info about me. I'm actually the chair of Alpha-1 UK, also known as Alpha-1 UK Support Group. I'm also the secretary of the Alpha-1 Europe Alliance. I've been a patient advocate now for some 20 years, so quite a long time I've been involved in the Alpha-1 community. And this session today is aimed to give you an introduction to Alpha-1 antitrypsin deficiency. It's going to comprise of 2 sessions. The first session is going to introduce the Alpha-1 Europe Alliance, and that's going to be delivered by Fernanda, I'm going to get this wrong, Aspilch-Ferro, who's also an Alpha-1 patient. She's also president of the Alpha-1 Alliance. And then there'll be a second session giving you the introduction to Alpha-1, which will be delivered by an expert clinician. So at this point, I'd like to hand over to Fernanda to tell us more about the Alpha-1 Europe Alliance.
Thank you, Karen. Just a little secret, I'm a little bit nervous, so bear that in mind. Welcome everyone today. Thank you for your time and your interest in Alpha-1 antitrypsin deficiency and what we do in the different with the different stakeholders. I'm going to share my presentation so that I can guide you through what I will be talking about today, which is mainly the creation and the history and the reasons why the Alpha-1 Europe Alliance has been created. So give me a sec to start sharing the presentation. Okay, there we go. You see, that is why I was nervous. I'm not very good with technology. So I will give an introduction to the Alpha-1 Europe Alliance. So like Karen said, my name is Fernanda. I'm also an Alpha-1 patient. I'm, as that said, I haven't been involved with Alpha so long because I was diagnosed in 2019 after having been wrongly diagnosed with asthma for the previous 2 years, something that is probably resonating to a lot of you. And today I stand before you not just as a representative of the Alpha-1 Europe Alliance, but also as someone directly affected by Alpha-1. And living with this condition has taught me so far the importance of advocacy and the power of a collective voice, which is what Alpha-1 Europe Alliance stands for. Let me tell you a little bit more about our history. So all this idea started around the COVID pandemic, which is when around the time I was diagnosed as well. Under the leadership of Karen and Marion, we started to have some monthly meetings to share information, to share our challenges and the needs and what we were living at that moment. And from this concept of the monthly meetings, we quickly went into the idea of how we could work better together in Europe. And our mission was actually personal. For many of us, including for myself, the access to augmentation therapy is very limited. So we all were focusing on, what can we do? What can we do, and how can we do it together, and how can we do it more than at our each national level? And what started like these simply monthly conversations quickly move into, sharing hopes and really willing to work together and being stronger together. And there is when the Alpha-1 Europe Alliance was born. The decision was taken around 2022 after some work we did to better understand what European organization is all about. So we interviewed several patient groups that have European umbrellas. We did an analysis of the pros and the cons. We gathered again in these monthly meetings, and we finally decided to go for it. We started collecting some funds to be able to get help. We engaged with a coordinator that some of you may know, that has been helping us to create the alliance. Her name is Veronica. She, together with us, did some preparation work. We established some working groups to look at different elements that were important to create such an alliance, elements like governance, like mission, vision, objectives, the dynamics for working together. And finally, in October last year, we registered our Alpha-1 European Alliance. And this picture you see in the slide is from our first general meeting that took place in November in Barcelona. Why do we exist, right? This is something we have been working on a lot as well, to see our mission, our vision. Here you can read it. All people living with Alpha-1 in Europe experience a better and longer life through a holistic approach to Alpha-1, with access to the best possible present and future treatment, and ultimately a cure. And for all of us in the Alpha-1 Europe Alliance board and in the team, our mission, like I was saying before, is personal. I myself and a lot of us are either patients or carers. And for many of us, we do not have access to the right treatment. For example, myself in Belgium, because the therapy is not reimbursed, I cannot have access to the therapy. So this was for us our main reason to exist. We want to have the best possible access to treatment to everyone, and we want everyone to experience a better and longer life through it. Some work we did also was about what we are going to do to reach that vision that we have. How are we going to do this? So we did at the time a survey with the members of the Alpha-1 Europe Alliance on how we could best support the work that we all do at the national level. And these were the topics that came up being the most important to do if we wanted to achieve our vision. So from raising awareness to advocating for access, Every action we take is going to bring us a step closer to a reality where patients like myself and a lot of us in the Alliance, we can access the treatment that we need. This is why also it's so important that we work together with all our stakeholders and that we raise awareness with them. We need all of you. We need the medical professionals. We need the industry leaders. We need as well the policymakers and all of us, the patients, to do this together. Let me tell you also a little bit more about who we are, and a lot of us are here with you today. So our members, we have now regional and national or international organizations that are part of the Alliance, and all of them in one way or another support the people that are affected by Alpha-1. So we are representing today, I think we are in total, and you can see it there in the slide, we are in total around 16, represented in 16, over 16 countries, and in total is over 90% of Alpha-1 patients across the whole Europe that are represented by the European Alliance. There you have the figures. Our member organizations, you can see them there from the different countries. They are some of them national, there are some of them international, some of them focused on Alpha-1, and some broadly on respiratory diseases. This is our board. I am the president of the Alliance, but for me, this is a team and it's teamwork. And I'm sure a lot of these faces are familiar to you. And we represent more than just patients. We represent families. We represent friends. We represent entire communities. And I do believe that together we are stronger and that together we can push for the changes that we need. I'm really very proud to say that we have become a very strong team. From the moments we started meeting together till now, we have built very strong relationships amongst the people in the board. And we have been very eager to create a safe space for us to share our opinions and to take joint decisions that are going to get us closer to our vision. And there are some shared values that we all have. We were very keen to be transparent in our actions and our interests. We are a very inclusive and diverse team, and also in our members and the community we represent. And it's very important to us to bring all of this with empathy and with real support in our approach. So I'm going to talk a bit more about our work, our channels, what we have been doing since we have been created. We really want to strengthen the European patient community through research, through advocacy, through awareness, education, and capacity building. We have been active in several channels. We are active in LinkedIn. We are active in X. We have been opening other channels recently, and you will see probably more of us soon in Facebook and Instagram as well, so that we can have a broader reach. What we have done recently in April was our first Alpha-1 awareness campaign for the Alpha-1 Awareness Day. We were very proud of it. So what all started, we wanted it to be in several languages, and we wanted to, of course, involve all our members, but it went really far beyond what we had anticipated. So we had, in the end, to translate, and we did that very happily, of course, the campaign in 13 different languages. We had 8 posts that were encouraging testing, that were calling for equitable access, to improve diagnosis. And we had 70 organizations all through Europe involved in posting messages at the same time. And we are really very proud about the results of this campaign. This is the participants. You can see really broad, and we really had a big reach across Europe. A lot of members were interested, and even not members, but other communities were very working with us to post the messages at the same time. And all the work we did, not only through this campaign, but also through the process that we followed to create the alliance. We have prepared a poster that we presented at the European Conference on Rare Diseases this year. And we were very proud that the work we did to create the alliance, and also through the campaign, and the work we did to prepare a good poster that could be seen as an example for others, got the attention of Eurordis, and we got to be one poster elected to be published in the Orphanet Journal of Rare Diseases. So we were very proud of this work, and this was a recognition for us of all the work that we have been doing in this last year. And there is more to come. We hope to very soon, we will have a roadmap for the years to come, something that we are going to build together with with all the stakeholders in an in-person event that we are organizing. And we are working hard to build this roadmap that will help us and guide us on the steps that we need to take to complete our vision and finally manage that we all live longer and better. So thank you very much for your attention.
Thank you very much, Fernanda, for that introduction and informative presentation about the Alpha-1 Alliance and the work that we've done over the past 12 months. It's been really great, all of us working together, as you said. So I hope everybody's understanding a little bit more about the Alpha-1 Alliance. We're not trying to replace those organizations in your countries, but we're trying to give us a voice where we can all speak as one and we can support each other. And we're achieving a lot, and it's been good fun. So I'd now like to introduce and welcome Christian Clarenbach. Christian is a senior pulmonary clinician at the University Hospital in Zurich. He is also the co-chair of EARCO, I'm also a steering committee member of EARCO, so we've been working together for a while now within the EARCO community. So Christian may tell you a little bit about that, but I know you're going to hear about EARCO later, but Christian's going to give us an introduction into Alpha-1. So hopefully every day is a learning day with Alpha-1, so I'm sure we'll all learn something. Thank you, Christian.
Hello, Karen. Hello, everyone. I hope you can hear me and see the slides. It's a pleasure to give this talk and also an honor. And I'm happy to start also with a little bit of history. And it goes back to 1963 in Sweden when this Professor Laurel, detected something in his lab. He was a chemist in a lab connected to a hospital. And he was looking at the liquid part of the blood, not the cellular part, but the liquids that are in the blood. And he let run them across a paper. He did that with thousands of patients and also healthy individuals. And I noted that in some of these paper pieces, we call it electrophoresis, some of them showed normal bands of proteins, but in just a handful of patients, there was one part missing, as you can see here, as compared to the normal piece of paper here. You could see that where he put the liquid of the blood on in this part of the paper, something was missing. And this missing band of proteins turned out to be the one present in Alpha-1 antitrypsin deficiency. But first he told his residents to look at who are these patients that have this missing band in the hospital. So they looked back to the hospital and were looking for the patients and found that these patients, or at least some of them, had something in common. And some of these patients that had this missing band had emphysema. And that was what he noticed and published in the first description of Alpha-1 antitrypsin deficiency. And also he noted that these patients were comparably young compared to other patients of emphysema. And also he had already a first idea that it could be an inherited disease, because when he was talking or wanting to get more information about their families, he found out that also the parents had problems with the lungs. So this was published in 1963. He was not only a very productive researcher, he also was married to a lab researcher, another professor, and they had 6 kids, what I found out on Wikipedia. Some further milestones in the history of Alpha-1 antitrypsin deficiency. So you've heard already now about the first detection and observation by Professor Laurel in 63, and later the association between liver disease and Alpha-1 antitrypsin deficiency was described in the USA. Then it took a few years to notice that the smokers, so the active smokers, they started earlier with the emphysema when they had Alpha-1 antitrypsin deficiency. So they found out that smokers are at higher risk for emphysema, and also that emphysema starts earlier in life as compared to the smokers who did not have Alpha-1 antitrypsin deficiency. In 1990, it was described that patients that have Alpha-1 antitrypsin deficiency form aggregates of this Alpha-1 in the liver, and that this is probably the reason why liver function might deteriorate in such patients. In 1999, it was the initiation of the AIR registry, the first big registry on Alpha-1 antitrypsin deficiency, where patients were recruited all over the countries and research was allowed on these patients. There were several publications coming out, and in 2020, as you have heard already, and some of the stakeholders of the European Alpha-1 research collaboration are also with you today. The IACO registry or international registry was founded. Another initiative to look at patients worldwide, to have more information of the disease with relation to the lungs, but also other manifestations of the disease. You will hear later about that from my colleagues throughout the day. How is Alpha-1 antitrypsin deficiency diagnosed? It's actually very easy, and it can be done by a generalist or your house doctor. You do a blood level test, and if the Alpha-1 level is lower than normal, it is likely that you have Alpha-1 antitrypsin deficiency. It's not a complicated blood take, and usually every lab is able to do that. If the level is low, usually a phenotype test or later a genetic test is ordered. The phenotype test checks for the presence of abnormal forms of the Alpha-1 antitrypsin protein in the blood. It's also relatively easily available. The genetic test is a bit more complicated because patients also need informed consent, and you have to talk to your doctor. You have to see what this might mean for the future. And usually these tests are sent to laboratories that are specialized in Alpha-1 antitrypsin deficiency, especially if you're looking for more rare variants, which is sometimes the case if you don't find a reason why Alpha-1 antitrypsin level is low. This can be done either by a blood take or a buccal swab like indicated below, where you send in material to one of the reference labs. And when you have the genetic test or the phenotype test, you can also see what kind of mutation you have. And this is also helpful to judge on the risk of disease. I indicated already that it is an inherited disease caused by a mutation in a certain gene. It's called the SERPINA1 gene. What does that mean? First, there are many variants known, but there are some classic variants that over appear again and that are most commonly noted also within the registries and the known studies so far. What does that mean? If you are a carrier of a mutation that leads to Alpha-1 antitrypsin deficiency, so usually a carrier means you have one healthy gene and one affected gene. So if a carrier woman and a carrier man get kids, then there's a certain chance that one of the kids gets two of the mutations. For example, if father and mother have one Z mutation, there's a 25% chance that one of the kids gets a ZZ genotype. In contrast, there's also the possibility that the disease is not passed on if the two healthy genes, here indicated by the blue strands of the DNA, are passed on and the kid is not affected and not even a carrier of the disease. And you also have a 50% chance that your kids are also carriers like you are. This is what we want to find out with the family history when we ask about the parents and about the siblings of the patient that we are confronted with and that we are consulting in our clinics. And also, this is important if we want to counsel on the risks of patients that want to plan a family. And if patients already have kids, we indicate how mutation can be detected in a kid and how family screening is organized. What is the rate of people being affected? The rate of people being affected we call the prevalence. And the most frequent mutations, as most of you know, is the Z mutation, which leads to alpha-1 antitrypsin deficiency. It's carried by about 4%, 1 out of 25 Northern Europeans. So they are carriers of the mutation, which does not mean that they are necessarily sick, because you need 2 mutations to become sick. The prevalence of alpha-1 antitrypsin deficiency is estimated to be 1 out of 2,500 or 1 out of 5,000 individuals. Since it's a rare disease, we have not so much data on the general population, but I'll indicate you something right now. It's not so rare, but frequently it's not diagnosed or misdiagnosed as asthma, COPD, or liver disease of unknown origin. So not always this test is performed when these diseases I just indicated pop up, because there's also a lack of knowledge, or doctors think it's caused by something different, like being caused by alcohol for liver disease, for example. There's some data where the general population was tested. These examinations from our colleagues in Ireland. Here, 1,100 individuals were tested at random. So they were not pre-selected. They were just tested in the population. And what you can see here, usually the mutations are not present. We have a MM phenotype or genotype. This is not associated with the alpha-1 antitrypsin deficiency. But as expected, there are some carriers that have a healthy M and a carrier variant, so a mutation called Z. And there are also other variants like the S or the SZ or the SS that were detected in this random sample. Instead, if you pre-select your population and you look for patients that have smoked or have COPD or severe asthma. So if you look for target populations that are at risk to having alpha-1 antitrypsin deficiency as a reason to be sick, then we have a higher prevalence, of course, due to this pre-selection, and we can find a variety of alpha-1 mutations and also alpha-1 deficient patients in this collection of 3,000 individuals that were tested. You can find more prevalence data dependent on the country where you come from. These are estimations, and you can. I won't talk about every country, but you can find them in this publication indicated below. What is alpha-1 antitrypsin? So it's a protein, or active protein means an enzyme which has certain tasks in the body. It's primarily produced in the liver and protects the lung from damage. And the damage is usually caused by inflammation. The M protein is the normal variant. So MM genotypes or phenotypes, they do not have alpha-1 antitrypsin deficiency. However, the Z protein is the most important mutation. And I showed it already when we were talking about the inheritance. These mutations lead to a change in the protein structure. And if you have a ZZ genotype, you are affected by the alpha-1 antitrypsin deficiency. That means you have 2 deficiency variants. We also call them alleles. That means that you're at higher risk for lung and liver disease. So in summary, without enough alpha-1 antitrypsin in blood, you're at a higher risk to develop a disease. This is a basic idea how we think of the evolution of the disease. So usually the factors that protect the lungs are equal to the factors that are working on the lung, regenerating the lung, but also causing destruction and degeneration of tissue in the lungs. So the alpha-1 antitrypsin puts this in a natural balance. However, if the power of the alpha-1 antitrypsin or the level of the alpha-1 antitrypsin is low, then we have an overweight of the factors that are able to destroy and the lungs and interrupt the tissues, cause inflammation, to disconnect the smallest area of the alveolar sacs, how we call the membranes where air gets into the blood and the oxygen is delivered. So in case of alpha-1 antitrypsin deficiency, you have a more powerful protease, so enzymes that are responsible for causing lung damage. What are avoidable risk factors? Most of them you are aware of that already, that smoking and drinking is not a good idea if you have alpha-1 antitrypsin deficiency. As for the liver, we know that the Z genotype, alpha-1 antitrypsin, it forms aggregates and they might get stuck in the liver and cause disease over time. So drinking alcohol, but also having a special a diet or being very overweight might increase the chances of a liver disease. In smoking, it is known that smoking itself causes lung inflammation, also in the persons not being affected by alpha-1 antitrypsin deficiency. Smoking attracts white blood cells to the lungs, and in alpha-1 antitrypsin deficient patients, again, the overweight of the substances that cause damage to the lungs accelerate the disease. So you cannot produce enough alpha-1 antitrypsin to counteract these enzymes, protease or neutrophil elastase, so both substances which are dangerous for the lungs. And also smoking causes a process called oxidation, which is also difficult for your alpha-1 antitrypsin to stay active. So if you're smoking and alpha-1 antitrypsin deficient, your lungs are at a high risk for disease. These are the basic principles summarized. So smoking on the one hand, causing oxidation, also leading to polymerization of alpha-1 antitrypsin in the tissues and also in the liver, as I just indicated, these alpha-1 polymers or aggregates come down in the liver and might lead to disease. In liver disease, it's fibrosis at the beginning, and if you call later stages of the disease, it can even be cirrhosis. And in the lung, we call it emphysema, the continuous destruction of the lung tissue may lead to the disease COPD, and finally also to emphysema, which is a stage where the membranes, where oxygen is taken up, disconnect and the lung gets overbloated. The clinical presentation of liver disease from alpha-1 antitrypsin. First, you need to know what the liver does in a healthy state. Usually it takes up proteins, carbohydrates, fats, and stores them in your body to be used. And it also produces a bile. It's a certain fluid that is important for your digestion. The liver also cleans the blood from toxins and, for example, also from processes that are connected to medication. What does disturb the liver in alpha-1 antitrypsin deficiency? Again, as I indicated, this alpha-1 that is mutated might form these misfolded proteins and aggregates that get stuck in the liver. And later, if a lot of aggregates get stuck in the liver, this may cause fibrosis and cirrhosis of a later stage. And it bears the risk that you are misdiagnosed by another toxin that may cause liver disease, which is mostly alcohol. So not every doctor is aware that alpha-1 antitrypsin deficiency can also cause a severe liver disease. And in this affected state, you can see here indicated these aggregates that get stuck in the liver and finally cause to the deformation of the tissue and the function of the liver that is not as well as it used to be. You can also have presentations of kids that are already affected by alpha-1 antitrypsin deficiency in early life, and about 10% of the infants with a ZZ mutation may present with the yellow skin in early years. That usually resolves in the second year of life, but there's a certain risk that also kids with jaundice can progress to fibrosis. In adults, typical symptoms of cirrhosis, if the liver is already severely damaged, is edema. So it means there's water stuck to the legs and also to the abdomen. Again, yellow skin, and it can be so severe that transplantation is necessary. And you also have an increased risk for carcinoma. In the lungs, on the other hand, you have the classical presentation is the chronic obstructive pulmonary disease. Obstructive means it is hard to exhale for the affected patients. And you have the emphysema, which is coming up in a later stage of COPD, where the oxygen uptake is less good than it should be, and also the lung is overbloated. The symptoms, the typical symptoms, are shortness of breath, especially when you're active, when you're running or walking up a mountain. You might have cough with some phlegm, and it might be just dismissed as smoker's cough. So here again, sometimes you have to rely on the judgment of the doctor and the knowledge of the doctor if he's aware of the risk of having an alpha-1 antitrypsin deficiency. Also, there's a certain risk of prolonged infections or lung attacks. We call them exacerbations. You may have heard of that. How do we diagnose the lung disease? Some of you who are affected might have seen such lung function testing labs. We can see on the exhalation, especially if you have to exhale very fast, we can see whether your lungs are still able to do that. And in a COPD, we can see that typically you have this concave deformation of the exhalation curve in the spirometry, and there's no change to after the inhalation of a bronchodilator, a medication that opens the airways. So this is a fixed obstructive airway disease. This is what we call COPD. And when you look at the tissues, a normal airway is open without inflammation, but in an inflammatory airway, you have the risk of having a tight airway, a lot of mucus in the airway. Also, the movement of the lung is less good. You have a hyperinflation, that's how we call it. So the emphysema bloats the lung. You have a limited movement of your diaphragm, as you also can see on the conventional pictures that your generalist can take in his office if he has a radiograph possibilities. Usually it is concave and it's easy to move with the diaphragm, but in COPD with emphysema, the diaphragm is flat and the ability to breathe is not as good. There's also the clinical presentation of enlarged airways and mucus that get stuck in the airways, and you get more frequent infection and have more sputum volumes. But there are many different causes for bronchiectasis. That's how we call the inflamed enlarged airways. Alpha-1 antitrypsin deficiency is just one reason of the bronchiectasis, and you have to look for it. And not all doctors are aware, because if you look at all the reasons for bronchiectasis, alpha-1 antitrypsin deficiency is only a small part of the big population of alpha-1 deficient patients. A very rare entity of alpha-1 antitrypsin deficiency is panniculitis. It is an inflammation of the bottom layers of the skin. It hurts, and the skin gets affected in its layers, where also infection is possible. This is a young woman I followed for a while. And the good thing is that these skin lesions usually all improve after alpha-1 replacement therapy. Usually these patients are young, and since it's so rare, it's frequently not detected and treated with other anti-inflammatory medication, which is not helpful in this kind of disease. So the therapy, if we come to the therapy, our current idea of the therapy is the substitution of alpha-1 antitrypsin. It is derived by human plasma, and it's not available in all countries, or not licensed in all countries, dependent on the healthcare authorities. But we will come back later throughout the day to the specific therapies. And also there are new therapies on the horizon. There are several companies investigating now and how to replace the enzyme, because the current way of therapy has also some disadvantages. You will hear about the advantages of the therapy later on. But the disadvantages are that you have to get weekly infusions, and there's not a treatment. It is not a treatment of the genetic mutation. So you only replace the enzyme. But this works quite well. You can increase the level of alpha-1 antitrypsin in your blood by doing these regular infusions once per week. This is the first description on how that worked in 21 patients that led to the approval by the FDA. So if you start here at a very low level of alpha-1 and you start with the infusions, already after 2 to 4 weeks, you are on a normal alpha-1 antitrypsin level that is known to protect your lungs from further deterioration and damage. I think we'll get to that later and jump over this. Who should be tested for alpha-1 antitrypsin deficiency? So all patients with COPD and emphysema, of course, asthma patients with severe asthma or not fully reversible lung function after using these bronchodilators, as I indicated. Also the patients with bronchiectasis of unknown origin, liver diseases of unknown origin, and of course this rare appearance of alpha-1 antitrypsin deficiency, panniculitis, as I just showed. Family screening is also important. Siblings and kids from homozygous alpha-1 antitrypsin individuals. Why don't we detect all patients? As I said, there's a lack of knowledge also among us healthcare professionals. So not everyone knows that alpha-1 antitrypsin deficiency leads to disease, and not everyone knows that it exists. There are recommendations to test or do for family screening. These recommendations are not universally applied, but we have also the good news that not all alpha-1 antitrypsin deficient individuals develop disease. So these are the ones that will not be detected. And for you are the patients, but also there are healthcare professionals in the call, also physiotherapists and other colleagues that are connected to disease. You are all the ambassadors of alpha-1 antitrypsin deficiency, and also raising awareness is your task. And this is why we are here today, I guess. I would like to finish with that and lead to Karen again for the discussion.
Thanks very much, Christian. I'm sure lots of our attendees today have found that really informative and interesting. Lots of information there. Excuse me. We've got some questions in the Q&A session. So I think one of the common questions that we get asked is, have there been any results or investigations with Alpha-1 and bronchiectasis rather than emphysema? And I know you did mention that in your presentation.
Yes, that's an important task also for our international patient registry. And we already had a cross-sectional analysis on bronchiectasis. And as you say, it's a bit more rare, but we will do further studies on bronchiectasis. We have another registry that is dedicated to bronchiectasis overall, which is the EMBARC registry. It's also well known, I guess, to the healthcare specialists being in the call. It's also supported by the European Respiratory Society. And we have us as Alpha-1 healthcare providers. And I think with the data that both registries provide, we'll get the field further, and we'll have the chance to also look for progression over time and therapies that are best suited to support these patients, and also about, for example, evolution of microbiology over time and therapies that help best to support these affected individuals.
Okay, so essentially we really need to do a little bit more research on to why some alphas get bronchiectasis and some don't, and being able to look at those two registries, we're hoping is going to be able to give us some more informative.
Exactly. Since we also, some of the registries are also interested in collecting blood and have their own biobanks, and this might also be a chance to look for different types of inflammation, for example, that predisposes to the development of bronchiectasis, also with regard for phenotypes, and for example.
Okay, thank you. So I don't know whether this is going to be an area of expertise for you, but we've got a query from somebody whose son is only 3 years old. There's ZZ, as we say here. He's still got an elevated AFP result. And can this be a case with the condition?
I didn't understand. Is it an enzyme that is of the liver enzyme that is increased? Is that
I
correct?
don't know. I don't know what an AFP is. So
if Alpha-1 fetoprotein, probably, which is a marker of liver disease. And I think this is a question that this should be, I think Pavel will be later in the call in the afternoon. He's the specialist for the liver. And if this is a specific question to enzyme uptake of a liver patient with that, I think it would be best suited if he keeps the question for later, because it's not, I think, a general question that affects the basics of Alpha-1 antitrypsin deficiency.
Okay, so our ELF team behind the scenes will push that one back. There was also another question here about the buccal test. Does it only evaluate the S and Z variants?
The ARCO or?
No, the cheek, I think it's the cheek swab test. Does it only identify?
That depends on the lab. At least for the lab we work together, which is Marburg, and I think Tim Greulich is later also in the call, who was one of the stakeholders from the Marburg laboratory, and also the other reference labs throughout Europe. In the cheek test, you can also look for rare variants, and you can also do genetic sequencing in a second stage. But this is a more complicated analysis, also more expensive. But if you're not succeeding with your usual buccal swab, so it can go like into a next round, and you can look at the full gene for all rare variants. And this is also how new variants got detected in the past years. So the usual test, the phenotype test, tests only the very usual variants. The normal genetic test in some of our labs only looks at Z, Z, S, and not so many variants. But if you send to the reference labs, or if you do a full sequencing of the gene, of course, you will have also the very rare genetic types that are being detected. But this is also a task for us as a EARCO group to make sure that rare variants get their voice within the organization. And we have now a few research initiatives, for example, one for M. Malton, maybe some of you are affected, that are about to be published. And we collect these rare variants, all variants that are associated with a low level of Alpha-1. And we are really interested to get these patients on board. And if you as a patient are not registered yet within the EARCO registry, please do so. And we'll be happy to assist you.
So when we're talking about rare variants, it seems that it isn't just the test that's conducted for you, it's also the lab that actually does the testing. Some can differentiate between some of these rare alleles, and other labs are not able to do that. And it kind of makes diagnosis quite complex for Alpha-1. Whoever said Alpha-1 was not a complex condition?
Just for the level in blood. But as farther it gets to the genetic test, the more complicated it gets. And there's also one initiative within EARCO for the harmonization of labs. I think this is what the question points at, that the quality and intensity the lab looks at Alpha-1 antitrypsin deficiency is different from lab to lab, and maybe also the techniques and also the interest in the disease and being a detective on that gene. So harmonization of labs means, for example, that the same probe from the same patient is sent to 3-5 different labs that are called reference labs. And then the labs, or the ones that are conducting the study, are able to compare the results of the labs. So from the same blood probe or the same buccal swab, and this allows us to improve the labs, because usually they should all have the same result, all the different labs. But this is not always true, and I think this is what the question in the chat was about, and not the same reporting, for example, how a mutation is indicated in the written report. And sometimes we are aware that there's some ways to improve. And this is also initiative of EARCO. We call the harmonization of labs.
Oh, and I guess it's also going to be down to the experience of the person who's undertaking the test as well. As in reading the results and looking at the results. So the lab technician. Yeah, okay. Still complicated. We've a way to go with testing. So I think one of the most common questions we get from patients is regarding MZ and whether or not they do get disease which is caused by Alpha-1. I'm going to read the question. It's quite a long question. You say that most likely carriers will not have AATD. However, in this person's family, they've got multiple generations who have all got symptoms, even the MZ ones. Mm-hmm. So they've got ZZs and SZs, and they've got more symptoms, obviously. And we know the severity of disease is greater, potentially, in those patients. But in terms of treatment, it is problematic that it's stated that one most likely does not have symptoms. In some register research papers, a significant portion, though not dominant, of the people that are carriers of Z show to have symptoms. some, I'd say somewhat does, so most likely not. So I think they're asking, what does most likely not mean in
Yeah.
real terms?
I mean, the same is true for ZZ. We have ZZ that smoked, and the variety of the clinical picture we see is huge. And we have ZZ that get transplanted, for example, with 45 and have a severely destroyed lung, but their counterparts are being 65 and only have a mild COPD. So the same is true, I guess, for MZ, but with a less intense clinical picture. Usually we don't see disease, but there are patients that are referred and they have a COPD. They are pre-selected, so the doctor did an Alpha-1 test because the patient has COPD. And we have an MZ. The level is not normal, but barely normal, or a little bit below the normal threshold. And that's difficult to counsel the patient, and beyond the normal recommendations to stop smoking or not to mistreat the liver. And I guess these patients are also not followed up as closely because most of them don't present with overt disease, and they are, since they don't have a low level, a low level that justifies or gives us the chance to give therapies, the interested is not the same. And but we also, for example, in the Swiss registry, we also register MZs if they are happy with it. And this allows us also to have a look at this population. But I know that, for example, in the ARCO, only the more severe deficient variants are registered. But of course, this is also an open research question. But I think you can explain it with a variety of disease presentations that is different phenotypes despite the same genetic is also true for other genetic diseases. So different clinical presentations despite having the same mutation. There are other factors in life, I guess, beyond genetics that are responsible on how the individual disease or human being develops over time with regard to their organs.
So I'm thinking back to presentations that I've seen previously from Professor Stockley over many, many years, where he's talked about other biomarkers that are potentially also having an effect on whether the severity of disease, basically in Alpha-1. So I'm guessing we've still got a heck of a long way to go in identifying these potential other biomarkers which are potentially interacting with the deficiency that we have, which may also affect MZ patients.
Right. And it's also, if you come back to the lab, a problem of repeatability in different areas or in different labs. If you do studies on biomarkers, you want more your own environment, your own lab you can trust on, especially if you have a biomarker that is not available in a usual blood take where the blood needs additional work on. Then it's basic research, and there are basic research initiatives, but it's difficult to do it across many centers. If you look at certain biomarkers that are, for example, polymers or some other prints of inflammation, there you need dedicated centers that stick together and really carefully work on their methods that at the end they all operate comparably to get a result that is reliable. This is difficult in a study to conduct like IARCO because we are having centers in Brazil, now in Panama, as I heard, and you don't have the control over all these labs that have certain interests. So we don't have a universal biobank yet for EARCO, but certain centers that collect samples and store samples that will allow to do research on in sub-projects. So it's not general projects within the cohorts, but if centers stick together that have a biobank, this might allow to look for rare biomarkers beyond our usual biomarkers like lung function or liver enzymes that are certainly taken in every patient and noted in the registry.
Thank you very much. Thanks, Christian. That's kind of the end of our session. We've overrun just very slightly. Thanks to you, Christian, and to you, Fernanda, for participating in this session.